about long-lasting symptoms in patients with COVID, and more specific in patients with who were hospitalized for their acute infection, trickled down. And a lot of us researchers were worrying about, but what about the non-hospitalized patients? Are they also suffering from the long-lasting symptoms? And is this maybe just the tip of the iceberg? And the upcoming days and weeks, more and more anecdotal evidence appeared in news outlets about long-lasting symptoms after COVID infection and also so-called mild infections. And the amount and also the extent of online peer support groups arose from all over the world on several platforms like Twitter and Facebook. It increased enormously, and patients try to connect with each other, but also share their story and find recognition. And with some of these groups, we work together with for this research project. And I will recommend it to all researchers who are listening, because it's really important. They are the experts, so and they have the lived experience. So please include them before your study, but also during and after. And in our study, we had several aims, and the aims were to characterize long COVID on the one hand and gain insights in the impact of long COVID on quality of life, work, and functional status on the other hand. And we recruited patients via online patient support groups in Belgium and also in the Netherlands. And therefore, we do have indeed a selection bias, but although we could answer our research questions. And the study was twofold. So we had a two-way follow-up survey. And the first survey was released in the beginning of June. And people who responded to the first survey also were contacted for a follow-up survey 3 months later. And in total, about 2,000 respondents answered the survey, and the majority of them were non-hospitalized patients. And only a minority of the non-hospitalized patients received indeed a diagnosis via nose swab or a scan. And the majority actually had a formal diagnosis based on symptoms by a medical doctor, or just on self-report they suspected to have COVID-19. And if we take a look at the clinical characteristics of these patients, you can see that they were relatively young, a mean age of 47 years old. They had 60% of them had no illness before infection, and the majority, 85% of them, reported a good self-reported health before infection. And if you look at the symptoms they reported during the acute infection, you can see there is an extensive list of symptoms. And also, the list was not long enough. A lot of people reported other symptoms, and this highlights a heterogeneous presentation of COVID-19, and that the symptoms can vary a lot from patient to patient, as already Betty told us. And if you compare the data from the acute infection with the data from the first survey and also the second survey, you can see that the prevalence of symptoms really decreased. So the length of the bars are in gray and blue are really lower than in comparison to the orange ones. But there isn't that much change between the blue and the gray ones. So little improvement in symptom prevalence was found over time in this population. And if you take a look at the symptoms itself, you can see that fatigue is by far the most common symptom in patients with long COVID, and it's highly prevalent. And we assessed it with a specific fatigue questionnaire in these patients. And this fatigue questionnaire that can range, and you can see it in the right corner, from 8 points to 56 points. And the higher the score is, the more severe the level of fatigue is. And these patients with long COVID reported that approximately 3 months after infection, a score of 48. And at 6 months after infection, a score of 46 points. If you know the scale, and it's ranged from 8 to 56, you can see that the level of fatigue is really high, and there is a high level of intensity of the fatigue. And over time, we saw a little improvement upon fatigue level. But also, besides the fatigue, also other symptoms are really common, like the shortness of breath and the headache. But the symptom list is much, much longer as this, and it's not just limited to pulmonary related symptoms itself, but it's a multi-organ disease. So it implicates also several symptoms like muscle pain, joint pain, the dizziness, nausea, the loss of smell and taste, etc. But what you can see is that also 1 out of 3 people indicated they had other symptoms than our extensive list we put together with patients. So, and these symptoms could be like sleeping problems, brain fog, concentration problems, memory loss, but also hair loss, etc. And this indicates the heterogeneous presentation of long COVID itself, and it really can vary from patient to patient. And despite the little to no improvement in the prevalence of symptoms, a large proportion of our participants did receive some form of aftercare. And 80% of them had received healthcare from at least one medical professional at 6 months after infection for aftercare. And 2 out of 3 received at least one care from at least one allied healthcare professional, and in particular, it was mainly a physiotherapist and in lesser extent a psychologist or a dietitian. And only a minority was referred to a RHEA program. But what about the impact of long COVID and the symptoms on quality of life? And here you see a quality of life questionnaire, and you see 5 domains: mobility, self-care, daily activities, pain and discomfort, and anxiety and depression. The first thing that stood out is that the domain of self-care is only in a minority of patients impaired. And this is good news. But daily activities and pain and discomfort were highly impaired, and about half of them, about half of the patients, reported moderate to extreme problems on these domains at 6 months after infection. And remember, these people were really relatively young and had a good self-reported health status before infection. So the impact is high. But what about work? And given the relatively young age of our participants, work is really interesting. And what you can see is that about 3 months after infection, 73% of all work time was missed due to their ill health. And after 6 months, this improved, luckily, to about 50% of all work time was missed due to ill health. So there was an improvement, but if people went to work, they still suffered from a high amount of impairment while working. So their time working was less productive in comparison to normal. At last, we also asked patients about their informations and care needs. And here you see a word cloud, and the bigger the words are, or the bolder they are, the more they were indicated by the patients itself. And I highlighted some of them, like recognition and understanding, because most of them are poorly understood by medical professionals, but also employers, colleagues, and other caregivers. So for them, this was really important, but also they had lots of questions about the aftercare, how it will, how it looks like, when I will get aftercare, will it help, how long is long term, and how long will my symptoms last, and how is recovery looking like. So lots of questions that remain unanswered, and hopefully today will bring us some answers already. And with this, I will end my talk. And to conclude, so long COVID is really a heterogeneous disease, and it can vary a lot from patient to patient. It's not limited to severe COVID-19 alone, and it has a significant impact on daily life and activities, quality of life, but also work. And understanding and being understood is an important first step, but more needs to be done. And with this, I will thank you for your attention.
Thanks, Martin. I'm just going to share my screen. Hopefully everyone can hear me. 1 second. Okay, has that come out? Or okay? Yeah, brilliant.
Great.
So first of all, obviously, thank you to the European Lung Foundation for inviting us to speak today. A lot of what I'll say is hopefully going to chime with what Betty and Martin have said, but hopefully that's a good thing. It's sort of about reinforcing messages. I mean, I think one of the main learnings over the last year is just how little we knew. So Asthma UK and the British Lung Foundation actually started work on long COVID back in March 2020. So as Betty alluded to, it's actually early studies from China that was showing us that there was lasting damage to the lungs, and that made us think, okay, well, there's something here that could go beyond COVID, and would be something that us as a charity needed to work on. But at that time, all we thought was that long COVID was about breathlessness. We didn't know much more. So what we did in response was, the first thing we wanted to do was actually create a way for people with long COVID, particularly long COVID breathlessness, to communicate with us. So we created a new website called the Post-COVID Hub in early April 2020, and that reached over 100,000 people, primarily from the UK. But it was also a way of us receiving information from people with long COVID. And I think that's got to be my central message, is we really need the views of people with long COVID, because this is a new syndrome. We're not going to know exactly where to focus strengths in terms of support or research without the input from people with long COVID. And I'm going to go over some of the insights that we learnt from people over the past year. So we created that website. We've had insight from 4,000 people with long COVID breathlessness. And in addition to that, we've been working as part of FOSS-COVID, which Betty mentioned, which is the largest national sort of flagship study looking into long COVID. It's focusing on 10,000 people who were hospitalized, but it's obviously connected very well with other studies that are looking at long COVID in the community. And I'll come on to this a bit later, but as part of that, we've overseen an exercise where we've tried to understand what are the priorities for future research and taking into account the views of people with long COVID. And throughout all of our work, we've been working very closely with people with long COVID. I mean, I feel like I'm pretty sure I speak to people with long COVID almost on a weekly basis. And in particular, my thanks goes out to people with long COVID as part of the long COVID support group, which has about 40,000 people, and Martin mentioned earlier. And just as a bit of this may be stating the obvious, but this is what we were hearing back in probably about April 2020. So people who had COVID early in the year and were saying that months later, they still had breathing difficulties, aching in their limbs, and extreme exhaustion all the time. And it was then we were starting to understand, wait a minute, this isn't just about breathing problems. So through some of that work, so through the Post-COVID Hub, we actually started to gather information on what people were experiencing. So through the survey of about 4,000 people with long COVID, we were getting this information of the wide range of symptoms that people were experiencing. And of course, it wasn't rigorous research at that point. It wouldn't be right for us to sort of ascribe different percentages to these different symptoms, but it was more that sense of an enormous range of problems. And I put a link to some of the early findings that we had, and including a Miro board, which is basically almost a sketch of the journey of people with long COVID from their initial COVID symptom to experiencing long COVID to their attempts to reach out for healthcare. And this is another key message, I think, about long COVID. It's not simply that one has long COVID and it's a steady, I suppose, range of symptoms or debilitation. It's actually that the symptoms come and go. And this is really something quite important, I think, that quite often people with long COVID have told us that they seem to be getting better, and just when they seem to be getting better, actually then their symptoms return again. And in particular, Betty mentioned how people with long COVID, there's a kind of high prevalence of women with long COVID. She mentioned 1.5 times more than men. And it's actually women who've been telling us that some women, their symptoms fluctuate along with their menstrual cycle. And that's valuable information for us, because then that helps us understand, okay, well, if that's the case, then that might be an avenue for research. It might be something that healthcare professionals need to consider when they're thinking about people with long COVID, i.e. that it's not simply a case of a single treatment and then that's it, and someone's recovery is steady. It is not steady. And then also something that Martijn and Betty both mentioned was this impact on people's lives. I mean, to me, it's been shocking and disheartening to hear how people with long COVID have lived the past year, and a lot of the people I speak to have been out of work, and yet trying to fight for someone to be hearing them, someone to acknowledge that their experience is actually something that demands attention and demands a response. If you think back to even, I would dare say, May last year, people weren't really even talking about long COVID. We thought something was happening, but there wasn't really the research set up to look into this. But I think that touch point with employers, and I think someone in the chat also mentioned this, is something that as a society, there needs to be a recognition that long COVID is occurring. I don't know if that's, I'm speaking too slowly and someone's just moved that. This is almost reiterating this point around insights from our surveys in terms of the impact upon work. So 75% of people, and this all chimes with the two videos that were shown right at the beginning of today's conference, but the huge impact on people's work, the range of symptoms, but also the fact that a lot of people are reaching out to their healthcare system and either they're not getting any diagnosis or they are being turned away from care. And then I just wanted to talk very briefly about FOSS-COVID. So this is the major study that is looking into long COVID in hospitalized patients, 10,000 people with long COVID. And it involves a range of different working groups looking at the different symptoms of long COVID, but it also involves the charities who are bringing their insights into how people, let's say with breathlessness or with problems with their kidneys, might be supported. And so it's almost trying to not start from scratch, but what can we try and do to help people? And how can we make sure that their voices are heard within these working groups? And so as part of this work, we undertook a prioritization exercise. I won't go into all the detail, but it was about us trying to understand, okay, so what do we need to focus on? This is an urgent health issue about which we know very little. So where should we focus our efforts? And key to this was getting the views of people with long COVID. So those working groups that I had on the previous slide, they were working with people with long COVID to understand what are the right questions to be asking. And they developed 115 questions, which then were sort of reduced down to 24 overarching areas. And then we put out a survey for people with long COVID. So we reached 900 people with long COVID, both hospitalized and in the community. Again, to sort of Betty's point about it's not really wise to be distinguishing between the two. We need to try and get the views of both. And then following that survey, we then looked at 17 questions. So that's both with academics, clinicians, and people with long COVID, to then get to 10 priority questions. And those questions will be released into a publication in the next month, we hope. But for now, I just wanted to share some of the broad areas that are being discussed. So this isn't everything, but I just wanted to share, I mean, perhaps these aren't even controversial, but this is what people with long COVID and the academics agreed on where we should be trying to focus. So the causes of long COVID, outlook for health, trying to have some tests to monitor progress, and understandably treatments, because a lot of people have had long COVID for a year plus and have had nothing to help them. So there are more areas, and hopefully within the next month we'll release a publication and we'll share that with the European Lung Foundation, and hopefully we can tweet about that in due course. So finally, I just wanted to share some of the work that we've been doing to help people with long COVID. So the British Lung Foundation, we've created some support for people with breathlessness, and you'll find that at this website here, and hopefully that can be of help to people across Europe. But also in the last couple of months, we've actually developed a partnership with NHS England, our healthcare service, and we're actually partnering with charities to deliver a service for people with long COVID. And what that will entail is trying to develop a simple framework to describe people's symptoms. So one of the challenges has been, or that we've heard from people with long COVID, is they're telling everyone over and over again, I've got fatigue, I've got breathlessness, I've got muscle pain, and they don't have a sort of framework to work from to understand whether this might be long COVID or something that they can go to their healthcare professionals to have a conversation. So we're helping them with that framework to describe their symptoms. We're providing support, as I mentioned, on different symptoms. So recognizing British Lung Foundation can support with breathlessness techniques. The British Heart Foundation will support on cardiac symptoms. And hopefully this will all be public in the public domain. Hopefully this will be of help to people across Europe in terms of at least seeing how we're approaching support for people with long COVID. And ultimately, we want to see better engagement with the health service, but also with employers, because I think that's a huge part of the story, as I said earlier, is that getting that recognition of long COVID is really key, so that when people are either experiencing that fluctuation of symptoms or actually having to take some time off work because they are struggling with their brain fog, that's really key, and there are services available. Just on that last slide, I just had my contact details. Like I said, the key message here is that none of this can happen without people with long COVID explaining, what their experiences are, and then that informing the support and the research that happens. So please feel free to reach out. Thank you.
So thank you very much to both Martin and Krishna for those really important presentations, including the patient surveys. We're going to now move into the question and answer session. So we're going to move into we're going to welcome back some of our previous speakers. We're going to welcome back Betty, and I'm also going to introduce Danny Altman, Professor Danny Altman from Imperial College, Professor of Immunology, who's going to be joining us for all of the sessions today, all to take part in this question and answer session. So if we can ask all speakers to put their videos on, and we'll start with asking the first question. And I'm going to start with Betty, because this is a question we'll start thinking about mechanisms of why things are happening in long COVID. A number of questions in the chat about why patients get brain fog and what we can potentially do about brain fog. So Betty first, anything from the research on multi-system involvement that explains this phenomenon?
Thank you, James, and thank you for the questions. So the insights that we have from our multi-organ imaging study are quite interesting. So I did mention very briefly that we saw abnormalities on MRI, which were basically suggestive of potential inflammation-related changes. And the reason for that is we looked at the correlation between objective measures of tissue health on MRI and blood biomarkers of inflammation. So it is possible that there is a form of grumbling inflammation that is ongoing, that is contributing to the way people feel. As for the question on brain fog, well, so that's also an important question because this is a very common symptom. Currently, we have not seen an association between the MRI markers in our cohort, but there has been a paper that was put out by the UK Biobank, which is a nationwide follow-up sort of biobank that undertakes comprehensive assessments, blood tests, questionnaires, and imaging of people who are willing to participate. And the UK Biobank had MRI scans of people before they had COVID and after COVID, and a lot of other assessments. And they have seen changes on the brain to suggest that the gray matter volume in some parts of the brain reduces in size or shrinks. And actually, when you look at other disease models that have similar findings, so they're seeing similar changes in diseases like Alzheimer's and Parkinson's. So there is obviously there is a working hypothesis that whatever's occurring in patients who are suffering from long COVID, may predispose them for longer, more permanent damage. And we really need to understand why this is happening. And there's definitely some markers on imaging to suggest this is happening.
Okay, I think that's really useful. I think that'll be of great interest to many of the people asking the questions today about. So brain fog has come up again and again in the chat and the Q&A. So I'm going to bring in Danny on this as well. Based on what you've seen so far, are there any clues in these studies that Betty's talking about or other studies that would give us an indication of how we might be able to treat brain fog or the neurological effects?
Sure. All I'd add to everything that Betty said is that, we all agree that we're talking about a multi-system, multi-organ disease. And when immunologists talk about that kind of stuff, the brain is no different to any other part of your body. So, if we think that there are white blood cells that can release things that are pro-inflammatory and making you feel rubbish, things like tumor necrosis factor and things like that, if they can do it in your kidney and your lungs, they can certainly do it in your brain as well. So we don't need special explanations for brain fog. We can use the same ones, and we can probably use the same kind of drugs once we sort out which are the right ones to give.
Yeah, so staying with that, so from Martin's survey and also from Krishna's data, this seems to be a very diverse condition with lots and lots of different symptoms. Is that to be expected even if the mechanisms are quite similar, as you're suggesting, Danny, or does it suggest that there's different mechanisms at play in different people?
So I accept that long COVID is a work in progress, and there are kind of stratifiers and there are lumpers, and that's the nature of medicine and trying to write the textbook in real time. For my part, as I'll try and explain in my talk, the immune system is all over your body and doing things all over your body. So I feel like I don't need lots of different explanations. I can probably work with a small set of explanations, but I'm open.
Great. Marianne?
Sorry. No. Don't have anything more to add.
Okay, so Krishna and Martin, one of the other questions that's come up a lot in the chat, I think patients are looking for a bit of hope. How often, based on the surveys and based on what you've seen from the reports, how often are patients getting better? And do you have an indication of how long it's taking?
I have to say, we don't from the surveys. I think it's been... I think I can speak from personal contact with people with long COVID. So the long COVID support group that has contact with 40,000 people, I think they have seen that some people have at least been able to return to work gradually. And I think one of the videos, Marlu, I believe, was mentioning how she had gone back to work. So if that might be a small marker that some people are seeing some improvement from those early days. But for the people that I've spoken to, it has taken the best part of a year, and I know that's not that might not sound like hope. What I would say is that I've never seen anything like this in terms of a response from the research community to try and understand what is going on, to try and understand treatments. We're seeing publications written in record time, and as soon as something is ready, it is out there. And just to the point of earlier around stratifiers and lumpers, I mean, I guess that is something, at least, that FOSS COVID has released a paper, and I'll put it in the chat in a second, but that at least for that, their early analysis of the first 1,000 patients in that study, we were seeing at least 4 main clusters, and hopefully that will lead us to understanding, okay, well, maybe it's some people with a certain range of symptoms will respond to certain treatments. I don't want to sort of promise more in terms of what will happen, but people are working day and night on this.
Yeah, and I think that's a great message. And Martin's one of the people who's working. So, Martin, any thoughts on trajectories of recovery or anything early on about characteristics of who gets better?
Actually, yeah, it's still early to say something about that, but I think we need to, about recovery, I think we need to ask our patients the questions if they feel they are fully recovered in comparison to before, after and before the infection, because nowadays we are always looking at just the amount of symptoms that are prevalent, but sometimes some symptoms were already prevalent before they got infection. If they had some like comorbidities like COPD or asthma, they're often suffering from dyspnea or shortness of breath. So I think we need to have like a good case definition about what is long COVID, and we are still, I think the researchers are still finding out this case definition. If we can speak, if we say someone is really recovered or not, because nowadays we are just based on symptoms. I think a good definition and good criteria are necessary to say something about the trajectory and if there is real recovery or not.
Yeah, important point. Danny?
Yeah, can I just sort of add a point and make a plea that you know, I think we all agree that the timeline to recovery is one of the most critical questions, and it's the thing that people most desperately need to know. Is this a 1-year question or a 2-year question or a lifetime question or what? And it's the one where the researchers and clinicians really lean on all of the patient-led support groups who have been the research leaders in this, because it's very hard for clinicians to gather the data. Because if somebody just drops out and leaves, is it because they lost interest, they got better, they died? We don't know. So we really lean on the support groups for that data, which is absolutely critical to understand the kind of decay curve of the symptoms and get a feel for, does it look any better at 6 months or 12 months or 18 months?
Yeah, completely agree. And I also completely agree with the comment that it's been the patients that have led all of the driving of this research agenda, which has been fantastic. Marianne, do you want to ask any questions?
No, I don't want to really I just want to say that I've been struggling with this now since end March 2020, and I've tried a different approach, trying just to work out and get better. Then I realized that was not really working. Then I'm trying to rest. I'm not sure that works really either. So you are kind of left in between. You tried, regardless of what I try, I'm still left in the same state, kind of. Slowly, I probably get better, but I don't know exactly what it is that I do, or if it's just the illness itself. And I think it is extremely frustrated.
Yeah. So, and that's a message that also came through in our earlier patient presentations. I think this frustration is clearly a big part of this, and a plea for understanding in several of the presentations today. I can see at the moment the top rated question is a question about potential reinfection. And I'm going to broaden this question a little bit to also ask you about the vaccine and whether people with long COVID should be encouraged to get the vaccine. So the question that's in the chat is, are people with long COVID more at risk of reinfection? And the counterpoint to that is if you could address the question of vaccination as well. I'm going to throw that to Danny because that's definitely got an immunology flavor.
Yeah, no, this is definitely my cup of tea and the kind of research that we and other people have done. So let me first of all talk about reinfection. So of everybody on the planet who's ever had natural infection with SARS-CoV-2, we know that maybe there's a tail end of 10% of people who've got the lowest immunity, who have the kind of normal, de novo risk of getting infected all over again. And so how does that apply to people with long COVID? So my experience of people with long COVID is that there are some who feel they may have got it because they had too little immunity, and some who feel they may have it because they had too much or hyperinflammatory immunity. And from what I've looked at so far, I'm not totally convinced that either of those are necessarily explicitly the case. So I take that to mean that somebody with long COVID has precisely the same risk as anybody else on the planet of getting reinfected. So, so it's no more or less a worry than any of the rest of us on the planet. So, make of that what you will. Obviously, lots of discussion about vaccination and long COVID, and the first major controlled trial is underway at the moment. Well, a few of them, one in the UK and one in the US that I know about. And from some preprints that are out at the moment on surveys, again from the patient groups, my reading of the data so far is that of everybody with long COVID who's been vaccinated, perhaps 40 or 50% report improvement, at least in the short term, and the rest are divided between the ones who say they felt worse and the ones who felt no different. So I think that's a work in progress as far as I'm concerned.
Yeah. Does anyone else want to come in on that, on either the immunology or the vaccine side? No. So another question that's coming up a lot in the chat is about the impact of exercise. So patients are sometimes being told to exercise, but they're finding exercise absolutely exhausting, worried that feeling means that they're doing harm to themselves. I'll start with Krishna and Martin, whether that sort of concern over exercise is something that's come through in the patient surveys, and then ask Betty from a multi-organ point of view what we think's going on there.
Yeah, I mean, I think I can say it's absolutely something that we're hearing from patients, that they're constantly seeing on TV, oh, well, exercise will always make you better. And for them, it's not. And I think that's been reflected in some of the studies as well. But yeah, absolutely something we're seeing.
Martin, anything to add?
Yeah, we didn't ask it in our questionnaire itself, but we left like an open text field so they could give some answer that weren't in the list, and we saw a lot of post-exertional malaise passing by, that people did some exercise and got a relapse afterwards. So about exercise and recovery, I think some people will benefit from it, but it will depend on the patient itself. So not everyone need to do exercise, not everyone will benefit from it, but some maybe will benefit from it, and it's not black or white, and that's a difficult thing, and long COVID is new, but we need to be cautious about that. Some people are telling us that they are experiencing some relapse, so we need to be cautious about that as a therapist, but also we do not have to exclude everyone, because maybe some will benefit from it.
Yeah, and so Betty, do we know anything at the moment about the mechanisms of that? So you made in your talk a nice distinction between the hospitalized patients and the effects of being in hospital versus the effects of COVID. And we know people who are in hospital get muscle wasting and deconditioning, and exercise is kind of our routine treatment for post-hospital rehabilitation. So do we know anything about the mechanisms of why this seems to be different for some people?
Yes, so absolutely, James. I mean, I think it really comes down to it is going to be quite a heterogeneous group of individuals, in the sense that there will be some people who will benefit, and I suspect when we look at the ICU literature and patients and data from patients who have received rehabilitation from being in hospital for a long time, it would appear that those who are admitted to hospital may actually have a stronger benefit from ongoing rehabilitation. And the reason for that are many. When you're in hospital for a long time, there's wasting of muscles. The muscles themselves that have mitochondria, which are little power cells, start getting depleted of the mitochondria. And of course, there's effects of therapies. So for example, steroids can result in wasting of muscles and just the acute stress of illness. So what a number of studies have shown in other diseases where people have been admitted to hospital for a long time is that rehabilitation really helps restore the mitochondria, restore the muscle bulk, restore muscle health in people. And it does seem to help some people, but it's not a one-size-fits-all solution here. And we know that there are some people who just won't recover the way others do. And it really should be tailored to the individual. And more research should go into understanding why some people tolerate it and why others don't.
So we've got a couple of minutes left. So I want to address something that came through in all of the talks, which was the need for more understanding. And Betty, you I think used the perfect word, which is a bit of compassion. Why is this currently a bit misunderstood? And what can we do to provide better information and make patients feel a bit more supported? That's a difficult question for 2 minutes, but I'm gonna throw that to Krishna first.
Thanks. I mean, I think it's obviously about us being connected to people with long COVID, constantly getting that information about answers to the questions that we're asking in this panel today, and adjusting what we're doing in terms of support and research based on their input. I mean, just on the last point around post-exertional malaise, it's through hearing from people with long COVID that we've changed our advice. So I'll post something in the chat in a second for all attendees, but even our advice on breathing recognizes that for some people that's going to get worse. So there are techniques that are deliberately recognizing that. So I mean, obviously we have our website, and obviously I posted my contact details, but we always want to hear more from people with long COVID. So please don't feel like we're not listening, or that your voices aren't being heard. That we want to try and make sure that they're heard by the right people, not just researchers, but even the people funding the research.
Yeah, very important. Danny, final comment before the break.
Yeah, my little bit of wit and wisdom that I think it's just a plea really for a bit of tolerance and understanding, because we've got the perfect group on this call. We've got a lot of patients and support groups, and also a lot of professionals, sort of medical professionals. And I can understand both sides. We've got very, very desperate patients who are desperate to restart their lives and get back to normal and work out what the hell is going on and get some help. And on the other side of the table, you've got a terrified healthcare professional, perhaps a junior doctor, who's been plunged into a clinic, has no tests to give, no understanding of the disease process, and a very angry person in front of them and doesn't know what to do for them. So let's just understand each other a little bit.
I think that's an absolutely perfect description of the situation in a lot of countries at the moment. And a good message to finish, which is understanding, compassion, and trying to work together to find some solutions. So we're going to take a short break now. So we're starting the break 1 minute late, but if we could come back for 10:45 UK time, 11:45 Central European time, for the next session on research, when we'll try and find some of the answers to the brilliant questions that our speakers this morning have generated. So see you in 15 minutes. So welcome back. That's 10:45 UK time, 11:45 CET. So we're starting the second session now, which is on long COVID research. I'll be chairing the first part of this session, but then Marianne and Professor Danny Altman from the previous session will be chairing the Q&A at the end of this session. So we're looking forward to a really exciting session discussing the latest in long COVID research. And it gives me great pleasure to welcome our first speaker, who is Professor Stefano Aliberti from the University of Milan. And he's from the End COVID Clinical Research Collaboration, which is a project I'm sure he will tell you about, but is an ERS project looking into the problem of long COVID. Stefano, welcome. It's a pleasure to have you with us.
So thank you so much, Professor Chalmers. It's really a pleasure to be part of this kind of meeting organized by the ELF, ERS, and Dragon, and I'm really enthusiastic to share our perspective. My talk would be on. Let me just. Okay, very good. My topic is, my job would be to discuss a little bit about the latest research, but I don't want to bother our audience. So I decided to organize my presentation in 3 different sessions. The first one would be to give you an idea about the kind of research methodology that had been applied for long COVID evidence. And then I will touch a little bit a couple of studies that I think might be recent studies that I think might be interest to our audience. And finally, I will discuss about the holistic approach in the management and the role of the ERS and COVID CRC. So as we mentioned over the past hour, the respiratory tract is the preferred site of infection of the SARS-CoV-2. However, we have learned, listening previous speakers, that COVID-19 is a really complex systemic disease affecting different cardiovascular, renal, hematological, gastrointestinal, CNS systems. And we have also learned about a plethora of symptoms that might persist in patients surviving severe COVID-19. And this is the reason why we are now discussing here about the post-acute and the long COVID syndrome that have been proposed early after the pandemic. The point is that only recently we started looking at data at a 1-year follow-up. So the first message is that our knowledge in terms of prevalence, risk factors, management, and impact of outcomes of different signs and symptoms of the long COVID is evolving. So at the beginning, we were talking about 12 weeks, then we talk about 6 months, then 9 months, and now 12 months. This is a map concerning all the different publications and the distributions of studies targeting the long COVID worldwide. And the message here is that, as you can see, data about long COVID are coming from most of the big countries all over the world, and publications are targeting different human body systems, not only the lung, but also the liver, the blood, the gastrointestinal tract, dermatological one. So we are having a good number of data in terms of distribution of sign of evidence on signs and symptoms of long COVID across different human body systems. However, if you take a look at the number of studies that specifically target different organs, and this has been shown by this graph, you see that in the majority of the cases, lung diseases and thrombosis, stroke, and neurological diseases have been the topic of interest of the majority of studies on potential long-term complication after COVID-19. And so this is the reason why we should focus also to increase the number of evidence looking at complication for other very important human districts, like the psychological one, the central nervous systems, or even the liver disease. This is a pretty recent meta-analysis that is in a preprint format, so not already published by Lopez Leon and co-workers. Up to January 2021, more than 18,000 publications identified with the idea of looking at the complications of COVID-19, 15 studies evaluated, and 55 long-term effects estimated on more than 47,000 people enrolled in these studies. 9 studies were mainly from UK and Europe, 3 studies from the US, and 1 from Australia, China, Egypt, and Mexico. The key message of this latest research is that up to 80% of patients that have been infected with SARS-CoV-2 actually develop 1 or more long-term symptoms, including fatigue, headache, attention disorders, hair loss, dyspnea, and as we previously mentioned. So as soon as this systematic review meta-analysis will be reviewed and will be published, this is an incredibly important amount of information for us. However, if we take a look at the quality of the evidence according to the different sequelae and organ evaluated in people who survived from COVID-19, you see that, for example, for data on pulmonary fibrosis, which is a well-known complication of COVID-19, we only have a small observational studies, while we have a large amount of observational studies looking at the lung function and the impact of dyspnea. In terms of cardiac involvement, for example, the myocardial inflammation, which is something that we are really interested now because we are starting evaluating more in depth this complication, was mainly based on a case series, while the evaluation of the function of the heart in terms, for example, of diastolic dysfunction have been evaluated through multi-center observational studies. And in the majority of the other area, like the hematological one, the neurological one, the renal, or even the systemic evaluation, you see that we are always based on observational studies. So we don't have very well done interventional studies that can change the trajectory of these complications. And in some cases, we still are based on data coming from case series or even case report. This is the second message I would like to share with you as a take-home message, which is just one of the examples of a patient-led research. This is an analysis of prolonged COVID-19 symptoms. It's a survey by a patient-led research team that came out at the beginning of May 2020. And the goal of this research was to capture the big picture of all the different experiences of patients suffering from COVID-19 with prolonged symptoms. So this was a survey, and the survey content and the survey analysis have been patient-centric. So the questions, the survey questions, and the symptoms were curated by patients themselves. Patients expert in research and in survey design, but the analysis was also conducted by the patient themselves, both qualitative and quantitative data analysis. And this kind of approach is really, really important, especially for COVID-19, because patients experiencing symptoms are in need of timely research and content relevant for them that might not be expressed by a physician-led research. So this is really important. In terms of common manifestation of COVID-19, we already discussed a little bit about that, and we know that it's a multisystemic disease involving the neurological, the psychiatric, the cardiovascular, the pulmonary, cutaneous, and a general, a systemic kind of sign and symptoms. And if we want to summarize a little bit the post-acute COVID-19 complications by organ systems, we touched in the previous presentation most of the signs and symptoms, especially the pulmonary one in terms of dyspnea, in terms of hypoxia and decreased exercise capacity, in terms of hematological complications like thromboembolic events, in terms of palpitation or chest pain from a cardiovascular perspective. Very important anxiety and depression, PTSD and sleep disturbances in up to 30–40% of the patients who are COVID-19 survivors. Renal dysfunction, endocrine dysfunction, some gut microbiome alteration. We have some good hypotheses about that. The air loss reported in 20% of COVID-19 survivors. And my presentation is mainly on adults, but we should also think about the impact on children and the so-called multi-system inflammatory syndrome. We have some very important data that came out over the past few weeks. We also have an idea about predictors and risk factors for long COVID. These published in the International Journal of General Medicine a few days ago. It's a nice review also for patients that can put together not only the prevalence of complications, but also risk factors. So we identified older patients and different complications according to age. We can use abnormal lab results during the acute phase, but also after the acute phase as a predictor for long COVID complications. We know that patients with previous underlying disorders or comorbidities might be more affected than other patients for complications. And then we also have miscellaneous factors that should be always individualized on the single patient. So there are very nice research on trying to identify risk factors, where the implication for us as a physician is to individualize the right path to monitor and to follow up properly the patient, not only after the discharge from the hospital or not only after the acute event in the hospital, but also after 3, 6, 9, 12 months, or even, we don't know now, but 2 years, for example. I'm a pulmonologist working in Milan, Italy, so I would like to share with you a couple of slides about pulmonary complications. We discuss about risk factors, and we know that there are patients at highest risk for COVID-19 pneumonia complication. These are patients managed in the ICU or in the high dependence units. Patients who are discharged on long-term oxygen therapy, patients who receive during the hospitalization or after the hospitalization positive pressure through continuous through CPAP or non-invasive ventilation. So we tend to follow more closely these patients during our follow-up. And from the beginning, these are data of 2020. We knew that there were CT features in COVID-19 affect that we were able to recognize not only during the acute phase, but also after hospital discharge. The importance of the CT scan have been put under the focus of us as a clinician and researcher at the beginning of the pandemic. We know that the CT scan can help us in identifying all the different aspects of the impact of pneumonia in terms of reticular pattern or ground glass opacity or consolidation during the acute phase and up to 4 weeks. And at the beginning of the pandemic, this is a perspective we published with Paolo Spagnolo in 2020. We started thinking about an evolution of the lung abnormalities into a pulmonary fibrosis for those who were hospitalized for acute respiratory failure and RDS due to COVID-19. With the percentages up to 20 and 40% of the patients. Also, the cardiopulmonary recovery after COVID-19 is very important. This is one of the latest studies published in 2021 in the European Respiratory Journal. I would like to show you this because this is a prospective multi-center observational studies that systematically evaluated the cardiopulmonary damage in patients who survived from COVID-19 at 2 time points, after 60 days and after 100 days. And through a questionnaire, but also clinical examination, laboratory testing, lung function analysis, CT scan, echocardiography. And what the authors found is that dyspnea was the most frequent symptoms, up to 36% of the patients, that there was an impaired lung function, especially in terms of reduced diffusing capacity, but also there was a cardiac impairment with a reduced left ventricular function. And sometimes also some signs of pulmonary hypertension, but these were present only in a minority of patients. And the good thing of this study was to a comparison between the signs and symptoms during the acute COVID-19 and during the follow-up phases. In terms of the evaluation of the CT scan, this study presented a very nice and elegant analysis through the evaluation of the CT severity scores done by radiologists, the evaluation of the pattern of pathological findings through the CT scan, and these and other important studies put the importance of lung function test and the CT scan at the top priorities in our follow-up of COVID-19 patients. This is another study looking at the lung function and demonstrating that the impairment of diffusion capacity is the most common abnormality in the lung function test, followed by a restrictive ventilatory defect, which is associated with the severity of the disease, according to a different disease severity, from mild illness to severe pneumonia. And pulmonary function test in general, not only a simple spirometry, but also diffusion capacity is now considered in the routine clinical follow-up for a specific category of patients who survived hospitalization because of COVID-19. Another important point of discussion is about long COVID complications in patients in people who have been managed at home. Because the long-term complications after COVID-19 are common in hospitalized patients, but the spectrum of symptoms in milder cases is not very well known and needs further investigation. This is a study published in Nature Medicine recently, where the scientists conducted a long-term follow-up in a prospective cohort of up to 247 home isolated patients and also 65 hospitalized patients in Norway. And they found that at 6 months, 61% of all patients had persistent symptoms, independently associated with the severity of the initial illness. And they found that up to 50% of home-isolated young adults between 16 and 30 years of age, they had symptoms at 6 months. Symptoms including loss of taste or smell, fatigue, dyspnea, impaired concentration, but also memory problems. So these are important data, important findings on young home-isolated adults with mild COVID-19 who are at risk for long-lasting dyspnea and also cognitive symptoms. The other big chapter is about the follow-up. So the majority of the data are on 3, 6, 9 months, but we are now having good data on 1 year follow-up. Like this one, this is a study published on clinical infection diseases recently, and patients were included at 5 months after the acute COVID-19, prospective design. Patient followed until 12 months after COVID-19 diagnosis. And what they found is that after 1 year, 23% of patients were completely free of symptoms. So only 23% of patients were completely free of symptoms. And the most frequent symptoms were exercise capacity, fatigue, dyspnea, concentration problems, problems finding words, sleep problems. And he also found that female seems to show a significantly more neurocognitive symptoms than male. So this is a big issue about 1 year follow-up and maybe 1.5 years and 2 years. If you had the chance to look at this data, it's a nice study because it's also comparing the evolution of the symptoms during the acute COVID-19 phase, and then after 5 months, 9 months, and 12 months, looking at the differences. For example, take a look at the anxiety or the hair loss. You see that there is an increase or decrease of these signs and symptoms, which is significantly during the follow-up. And this is important for us because if we need to individualize the kind of testing to do in these patients, these are very important data. This slide is showing a podcast published in Nature, identifying the importance that COVID-19 has in terms of lasting disability or ill health. If you had the chance to listen this podcast, I would like to strongly recommend. And this is a podcast where the author discuss there are public health experts that are evaluating the impact on disability adjusted life years, the quality adjusted life years, and the new data that are coming out from the literature are showing that COVID can leave millions of people with lasting disability or ill health. And the speakers are asking to change the lens through this perspective, especially after all the data we have right now. The last 2 slides are about the holistic assessment that we as a physician are putting in place in the patients in the post-COVID-19 clinics. We tend to assess globally the patient, but also the lung problem, breathless, oxygen requirement, fatigue, anxiety. And the key message here is to try to build up a multidisciplinary COVID-19 clinic. There are plenty of these COVID-19 clinics that are based on an interaction of different healthcare providers, looking at the different body systems. So we have not only the pulmonologist, the hematologist, nephrologist, primary care, neuropsychiatric. So the key of success to monitor and try to reduce the burden of long COVID complication is into a multidisciplinary approach between the hospital and the community, working with a work between hospitalists, healthcare professionals, and GPs, and try to identify the specific area where we can do something for our patients during not only after hospitalization, but at least up to 1 year of follow-up. So I would like to conclude with four major questions that might be of interest for you. First of all, we know that long COVID exists, but actually how many people get long COVID and who is most at risk should be a little bit more elucidated, especially with a long-term follow-up, 1 year, 2 years. The underlying biology of some of the long COVID signs and symptoms is not completely clear and should be investigated, because here we might find some targets for therapeutical interventions that can change the trajectory of our patient history. Thirdly, what is the relationship between long COVID and other post-infective infection syndromes is interesting, because we know that most of the viral upper and lower respiratory tract infections might have a long-term effect, but now we are starting thinking of something different for COVID-19. So comparing with different situations, different viral infection might help us as physicians and researchers to better shape the management and the intervention for our patients. And finally, what can be done to help people with long COVID in a practical way, in a daily based way, is really important. What I mean is to design randomized controlled trials of practical intervention that can change and can ameliorate the quality of life of people suffering of long COVID-19 consequences. This is one of the experiences that are worldwide, that are present worldwide for the long COVID area. This is the European Respiratory Society and COVID clinical research collaboration, which is a network of physicians, patients, researchers, but also pharma company and other stakeholders that want to work on consequences of COVID-19 infections, particularly in patients who have been hospitalized, with the aim of merging different national initiatives in Europe that are studying the long-term effects of COVID-19. And we want to build an integration platform that can allow us as a researcher to better interpret the data and to answer COVID-19 related research questions. There is a website, you can Google this, just put ERS and COVID CRC, and feel free to send me an email if you are interested in this and you want to cooperate. With this one, I would like to thank all the organizers, and I'm happy to take questions during the question and answer session. Thank you.
Thank you, Stefano. This sound was really interesting. I would like to announce the second speaker, Bryce van Eekhout from the Dragon Project, who is going to be announcing the Dragon Project research project later on.
Thank you very much. I hope you can hear me correctly.
Yes, very well.
Quickly share my slides. There we go. Let me know if there is any issue. So first I want to thank the organizers and the European Lung Foundation for creating this panel discussion and for inviting me. So my name is Brice van Eekhout. I'm the CEO of Communicaire, which is a startup working on patient support solutions for patients with chronic diseases. But I'm also here as a member, as a partner of the Dragon Project, which you might already have seen in some slides this morning, as the project is actually focused on increasing global response capacity to the COVID-19 crisis, but also to future pandemics. So in the Dragon Project, we are mostly involved in a subsection of it, which is about patient empowerment through decision support systems. We're doing this in partnership with ELF, ERS, and BioSci Consulting. The main goals of the project, the subsection, are fourfold. So the first one is really to try to bring the perspective of patients inside of the project and its developments. This has been done through the creation of a citizen and patient advisory group, but also by participating and getting patients involved in conferences such as this one. The second big pillar is about creating a wider stakeholder community. So there we are trying to gather the perspective also of clinicians, researchers, medtech developers, but also decision makers, for example. The third pillar, which is most the subject of today, is really about the development of multiple apps for the support of patients and citizens throughout the COVID-19 crisis. And the last one, of course, is the integration of what has been created inside of the Dragon Project, which is mainly about decision support systems, so predictive models inside of the tools that we are developing, so that it can also really benefit to patients in the end. So Dragon wasn't designed to work on long COVID, as the project was actually written in the early 2020. But we had to evolve and adapt since we want to develop solutions where we can add the most value, of course. And we can see that there is a shift of focus towards also long COVID, as this appeared to be a very relevant subject. It's touching a large fraction of the population. And we had insights on this, for example, through different testimonies of patients, such as the one of Ellen Parks, which was gathered by the European Lung Foundation. Of course, this is extremely relevant. However, it's still very difficult to develop solutions. First, because we have a large panel of symptoms, as we've seen also in the last talk, and because we are still at the early days of research done on long COVID. As the Dragon Project is a European project, we wanted, in parallel of the development of our tools, to work on research which is built upon the insights that we already have, all the research that has already been done, and trying to do this on a pan-European level. And here, in the research that we want to do, which is a study called COVINCI, we really want to focus on the evolution of symptoms of patients after COVID-19. The COVINCI study is a year-long study that includes patients which have had a positive test of COVID-19 in the last 6 months, that are majority of age and are able to use a smartphone. And basically what we ask participants to do is to regularly just answer questionnaires during a 1-year period. For this research, we've built a specific digital tool, as the whole research is done remotely, and I wanted to quickly present it to you. So here the participant goes to the platform, and before actually being a participant, it's about decision making. So do I want to be part of the research? So the first parts are about eligibility. So we check whether you're eligible for the trial. And we also present some information modules about the research. Then we have a short quiz, which makes sure that you understood the information correctly. And then we try to gather preferences to make sure that there is a match between the trial and the patient, that the patient is actually interested to participate. The second part of the app is more about the participation. So first, you're able to register very easily by signing an electronic informed consent. And then we can start working on the questionnaires themselves, which are in different format, and most of them are questionnaires which are completely validated and are already used in research, but really targeting long COVID symptoms. So where are we today? We are getting now the final ethics committee approval. And we still need to translate the tool in different languages, but we're really close to launching the study. And then the next step will be publishing results, of course, but also to use what we've gathered to develop a support solutions. So if you're already interested, if you have had COVID in the last 6 months, a positive test, and you're interested to participate, don't hesitate to already go to the link here or to scan the QR code. It doesn't commit you to anything. It just means that if you provide us your email address, we'll just send you the information as soon as the study is starting, so that you can decide whether or not you want to participate. So what is the point of this? Of course, the research part is also about making a tool to support patients. Before even working on long COVID, we are already finalizing a first prototype of a tool to support patients that are positive to COVID, but that can be monitored from home. I think the tool is interesting also in what we have discussed today about the need to get informed and to find the right information. So ELF has done tremendous work by consolidating a lot of questions that were asked by patients about COVID and long COVID, and to get them answered by clinicians. And this is the type of information that we will gather inside of the information part. Then, of course, we try to monitor patients through symptoms and parameters. This can be done manually, but we also have some devices which enable to automatically input the data inside of the app. And so you get a better communication with the clinicians from the hospital, which are able to actually monitor you and create video conferences. So it's all about getting a better communication and an efficient communication in a system, a healthcare system, which is currently under pressure. So this concludes my presentation. If you're interested again in this research project, don't hesitate here again to scan the QR code or go to the link. And of course, I'll be part of the Q&A. If you have any question, don't hesitate to do so. Thank you very much.
Whoops. Hi, thank you, Bryce, and welcome. Sorry. Thank you, Bryce, and welcome back to all the speakers for the Q&A. I think this has been very interesting, and I see there's a lot of interesting questions. So now will there be questions for Bryce van Eek and then Stefano and Betty Aman? I don't know where Danny went. Oh, there is Danny.
Yeah.
I let Warbeek go to you. So
one place I think we thought of starting is that people had asked about whether there could be a poll of how long people have had their symptoms for, and Claire was going to look at setting this up and asking the questions. Is that a good place to start?
Yep, I think we've got a poll ready to launch. Yep. So you should see on your screens a poll about the duration of your long COVID symptoms. So it'd be fantastic if anyone who has got long COVID would answer that question. So how long have the symptoms lasted? Is that up to a month, up to 3 months, 6 months, up to a year, or already more than a year? So anyone who has long COVID or has had, please do answer that poll now. You should be able to see the results now. Danny, can you see them on the screen?
Yes, so I think people can see, so we've got a spread where the largest groups are the more than 1 year group at 30% and the up to 6 months group at 32%. Excellent. Good. So are we going to our main Q&A now for this session? Marianne, did you want to select some questions, or do you want me to?
I prefer that you select them. I'm starting actually to be a little bit tired.
Yeah, no, that's absolutely fine. So I thought that one of the questions that's come up recently in the chat that's of interest is that we've got many countries represented here and many different states of play in terms of long COVID clinics and clinical care. So I wondered if anybody had any views about kind of best practice or worst practice and how we're going about this and what's working. Does anybody on the panel want to suggest how they'd like it to work or how it's not working?
So if I may, Danny, I might start off with our experience in Oxford. So we have a very comprehensive team looking after long COVID patients, which comprises of respiratory physicians, intensive care doctors who are managing them, managing patients who are discharged from hospital, psychology support and physiotherapy. What is currently missing is the lack of other specialty involvement. And I suspect the problem right now is that the NHS is overburdened by referrals from patients who have had long-standing diseases and who've had to essentially wait for some of their investigations and treatments. So the healthcare system, at least in the UK, particularly in Oxford, and I'm sure in other places as well, are really struggling to meet the demands of all patients, not just long COVID patients, but also patients from other. So, I mean, I think that there really has to be a restructuring of services. And I'm really looking forward to a multidisciplinary approach for every chronic disease rather than long COVID. And that way, you just have, a more comprehensive assessment for patients that come through. And you can refer them in the same clinic to, say, a cardiologist if you're worried, rather than wait for 2 or 3 months before the patient goes and sees a cardiologist or a respiratory physician.
If I may add something, Jenny, another important challenge is also the involvement of the general practitioners, at least in my reality, because our population of patients who have been hospitalized because of COVID-19 and have been discharged, we tend to organize a very nice follow-up in the hospital after 1 month, 3 months, and 6 months, and so on. But it's very difficult, at least in my own reality, is a good collaboration with the general practitioners. Maybe because we don't have good data from the literature of this kind of interaction between hospital and the community. And also what I think we are missing as hospitalists are those patients who have been treated with a mild moderate disease, treated in the house, maybe with oxygen therapy, that are out of our radar, and we cannot put in the follow-up multidisciplinary clinic in the hospital. And this is, I think it's a interesting amount of patients that might need our help.
Great. Anything else? Bryce?
Yeah, maybe I can just add something from the discussions we'd had, because we had a focus group as well with clinicians to talk about long COVID, was about the fact that although there is a possibility to help patients in an outpatient fashion from home, there is still a lot of questions about being able to monitor whether the program that they are following is doing them good or not, and to assess whether they are able to follow programs and what level to do so. So there is a lot of questions still about what is the amount of training that patients need in the beginning at the hospital before they can be released and follow a program from home, which is still something we're trying to figure out.
Can I just I know Marianne has also been selecting some questions. Can I just pick up on one other one that I saw that I think we haven't really covered yet, which was about kind of the health economics and societal implications of any long-term disability. That, you know, we don't want to make this feel or sound any worse than it is, and we hope for the best, but we haven't fully embraced you know, the health policy planning, the health economics, and the social science aspects of this. Who else do we need to be talking to, and what kind of conversations do we need to have? Who wants to start with this? Because it's really a scary one. It also has, you know, employment law implications.
Jenny, I lost you for a sec for technical issue. Can you?
It was what kind of planning and conversations do we need about the employment law and health economics and social science, and, you know, all of the non-clinical societal implications?
Well, this is one of the most frequent questions that patients with long COVID are asking me in the clinic. Especially because there is an impact from a neurological, psychological issue on work. So, and we don't have a clear law in Italy, at least in Italy, in my region, about that. And it's really tough for us to put together a letter because also the evidence is not so strong in terms of guidelines that we can really push strongly in the letter. You as you don't have to do something at work just to be concrete. So unless the patient is really disabled and cannot go out from the house, or has clear symptoms during the work hours, then we don't know what to do actually as a physicians. Because we are not supported by the local and national law.
Yeah, and to chip in my bit, I think this is one of the areas where we really need international agreements and international standards, because we can't all reinvent this wheel, you know, and people in all different countries have the same requirements and the same rights, and we kind of need to start off in the same place to try and agree this.
I think the other problem, Danny, is that the whole concept of diagnosis of COVID and long COVID. So you know, that opens another can of worms, because you know, there are employers that says, did you have a positive PCR test, or did you have a positive antibody test? And then, you know, we know that the antibody levels don't last for long, and, you know, in some people. And so, yeah, it is a really difficult question. And I think probably one that even the health minister is going to struggle to answer. Yeah.
Yeah. Anybody else? Yeah. Yeah. So I think there's work for us all to do to try and push the agenda, you know, nationally and internationally.
I totally agree. I think that I have worked with many different nations, and I think that we all tend to define things differently. When it doesn't matter the subject, one country finds something more important than the other. Always. So I think that is a very good approach, and I think that's a more collaboration between the countries. I think is extremely important in this.
And again, I think it's another area where we need such strong collaboration between the patient groups and the researchers and the clinicians, because it takes quite a lot of courage actually to stand up, to employer groups and stake your case.
Yeah.
So I'm trying to see which other questions are looking popular. So I can see we have a lot about a range of different symptoms. Would anybody like to comment about, I can see questions coming up about long COVID in children that we haven't really discussed, which is, I think a very large group. And for example, in the UK, where I'm speaking from, a very hot topic at the moment, because we seem to be drifting towards a policy that it's okay to let COVID just rip through schools because children don't really matter and aren't affected. And it's become a very active debate in this country. So I'd be interested to hear opinions. I think we agree that notwithstanding the caveats about a higher risk in older people, I think we all agree that long COVID is a real thing across the life course in all ages that get infected by SARS-CoV-2.
So if you, I'm not a pediatrician, Danny, but I can comment a little bit. So to me, let me tell you something general. So since children appear to be less at risk of severe COVID-19 in comparison to adults, there might be the feeling that they could receive less attention from physicians and researchers because of this. However, we know that if we take a look at the literature, the MIS or PIMS, which is the syndrome I talked to you a few minutes ago, is present and it's a reality. Usually, it appears 2 to 6 weeks after the infection. There is a plethora of symptoms with persistent fever. Mainly GI syndrome, also conjunctivitis or even headaches, and usually they improve. So all these symptoms tend to disappear in few weeks. However, after in some children, it seems that after weeks or even months after the diagnosis of COVID-19, they also have a long COVID. Okay, so it would be great to know if, from a pediatrician point of view, how is the comparison between the long COVID clinic we have in our adult patients and what they are doing in children. I'm not doing that practically every day, but I collaborate in some sense with our pediatricians. And the way to think is pretty much the same in terms of the lung. So pulmonary function test, lung ultrasounds, more density scan in order to evaluate the pulmonary involvement. Then they have a big expertise in inflammation, in systemic inflammation, and in all the long-term inflammatory complication that children might have. We don't have as a pulmonologist of the adults. Still less evidence, and in my opinion, at the beginning, a little bit underestimated kind of situation.
Thank you. Yeah. So I think we're going to another break in 1 minute. There's a question in the chat that I've been kind of looking at for a little while now, puzzling over, which is there a difference in long COVID profile according to which variant you were infected with? So in my lab, we're always racing to develop the story on each new variant as it comes along. We don't yet have a story about long COVID with different variants, and I don't think anybody else does. But I'd love to know if anybody on this call has any evidence, anecdotal evidence. It was different after Alpha, or it was different after Delta, or anything really important to know. I certainly don't know. Let's leave it out there in case anybody can tell us the answer. So I think we're going to have another break, which will be for 15 minutes, which means returning at, is that 11:55 UK time, 12:55 European time, and we'll see you then.
Thank you all.
Thank you very much.
So welcome back, everyone. The conference is restarting now. It's 11:55 UK time, 12:55 Central European time. I hope you had a nice break. And I get now to introduce the final session, which addresses the absolutely key issues of how do we treat long COVID, how do we rehabilitate people with long COVID, and how do we support people with long COVID. And so I'll pass on now to Marianne to introduce the first part of this session. Is Marianne there? Oh, there we go.
Hello. I would like to say welcome back after the break. We will start session 3 now, where we will talk more about treatment and rehabilitation and support. First of all, we would like to show another video of the 2 patients we met earlier, Malou and Natalie, where they will talk about their experience about treatment. Hello, I'm a little bit unsure if somebody heard me talking.
Yep, we heard you. The videos are just coming now.
So I think around 2 to 3 months, it still wouldn't go away. It's like a flu that never goes away. You wake up and you hope, oh, is it getting any better? And it's not. I called the doctors and they said, well, just keep still. And yeah, and after maybe a week or something, I was talking to a supervisor who used to be a doctor before she was a psychotherapist. And she looked at me and she said, oh, you really have problems breathing. Maybe you should check in the hospital or call there. And I went there, and but my saturation was fine at that moment. So they just sent me home again. And I was terribly ill for 6 weeks or something.
Without being arrogant, because I'd been part of this community and was actively researching, was listening to people who I kind of respected in terms of what they were saying, and it was all aligning, and was hearing about people's like quite negative experiences with some GPs, but also being aware that GPs just weren't ready for that. How were they to know what it was, how it was going to present? They didn't. They're not long COVID experts.
And I read everything on Facebook and in papers, and but there was not really medical treatment. I called the doctors, the family doctors, 3 times, but they didn't really have good advice. They told me I did too much. I didn't do anything. So it was really difficult to do less than I did.
I'm lucky that I had a really good doctor who I dealt with a few times throughout this, and also latterly when I had an experience of quite awful vertigo and labyrinthitis, which I think was a byproduct of long COVID. And she's just someone who I really respected, and she respected me, and she kind of knows of me because of my background in perinatal mental health. And she was listening to me and she said, yeah, it sounds to me like you might know quite a lot about this. You could even tell me some stuff about what you're hearing from the groups. And I thought, that's great. We need to be sending our GPs the latest insights so that they can be sharing it in the clinical world, obviously where it's validated information.
I had to go over my boundaries. I had to, because they want to test it. And then I had a really bad, for 6 weeks. And after that, I improved little bit by little bit, a little bit. So it helped me to look in months, because you don't feel any improvement in 1 month. But if you look back in, hey, what could I do a month ago, or what could I do 3 months ago? then you do see that you are getting a little bit better every 3 months. It just goes very slow. So it takes time to, to accept that you have to be really patient with your body, and that not everyone will understand you.
I think for some people, the psychological impact of it is greater than the physical, and the physical is pretty intense. So that gives you some degree of perspective on it. And I know for a fact there are a lot of people who are struggling with quite deep depression at the moment and anxiety. I've become way more present with what's just unfolding now and less preoccupied about how's this going to look in 3 years' time. Well, who knows? I'm just grateful to be alive now, to be honest with you, and that's a good thing.
I have ADHD. I'm going in bam 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 fast lane. So I was really working a lot, studying a lot, being here, there. So I cannot do it anymore at this moment, but I don't know if I want to also. So I at this point, maybe sometime it will kick in again, that I want to do another something, but this moment I want to just relax.
So I think we have to say a big thank you to Marlu and Natalie for sharing their stories, very powerful stories of having long COVID, and now their experiences of treatment and trying to access treatment. And so we're moving on in session 3 to talk about that in more detail. And it's now my absolute pleasure to welcome back Danny Altman, Professor Danny Altman from Imperial College in London, who's going to give us the presentation on treatment of long COVID. Danny, welcome.
Thank you. Great. So I'm hoping people can see my screen. So people would have gathered, I'm an immunologist. I work at Imperial College in London. And I want to take a few minutes to talk about long COVID. What do we know? What do we need to know? And how does this lead to future treatments? Okay. So I know we have people on this call from many different countries. I'm speaking from the United Kingdom, where there was quite a sort of rapid move into long COVID clinics, although perhaps not always with the results that we hoped for, despite heroic efforts. But if we're talking about what kind of meaning clinical support could we get or do we want from long COVID clinics, some of the obvious questions to think about: who will refer you there? How will you get there? What kind of diagnostic certainty will you need to arrive there? What clinical specialties will sit in them? We've already talked, and we'll talk some more about how incredibly multi-system this disease is. And if we're talking about many millions of cases across the world, who are these staff and where will they come from, and where and when will they have been trained? And when these people are sitting in their long COVID clinic, what will be in that clinic? What specialist equipment will they need? What tests will they apply to work out what's wrong with you? And how to deal with the fact that a person's symptoms may relapse and remit and move between needing the support of a rheumatologist or a cardiologist or an endocrinologist, or you can see what I'm getting at here. And if you put all of that together, how is this person going to work out what type of management, what kind of therapeutics, what kind of medicines will help the person in front of them? And the big scary question that we all worry about: how many years do we need to plan these clinics for? Certainly, in the UK, I think there's no particular long-term planning about it at all. And of course, we don't know whether this is, a 1-year question, a 5-year question, or more. So I was asked to talk about treatment now and in the future, but I'm not terribly good at following instructions. But also, more than that, I didn't really want to get into that kind of, Donald Trump kind of territory of rumors I've heard from my friends of things that have worked, or, pouring bleach down people's lungs, or whichever one it was that he liked. So rather than talking about things I know that friends have got to work, I thought I could give a more usefully a kind of general talk about where the answers come from and what kind of answers we're after. So I hope that's helpful. So many months ago in the British Medical Journal, I got together with Rosemary Boyden, and we put down our kind of manifesto, really, of what we thought was needed to try and advance understanding of long COVID and treatment of long COVID. And to summarize of the, by all means, I'd be very pleased if you go away and read the article, but to summarize what we said, we felt at the time very frustrated that there was a lot of counting of cases, but not much doing. And I think we had the line in it that we had to move from the observational to the interventional. And of course, moving from observation to intervention implies that you know how to intervene and that you have some kind of rationale for your intervention to actually do something useful. So in a sense, that's what the rest of this talk is about. So as I said, I'm speaking from the United Kingdom, and people may be aware that here what's happening is that there's a lot of debate and a lot of controversy at the moment about government policy, where there's talk about a kind of tolerance for ending our measures to limit COVID-19 cases, accepting that we'll move into a phase very rapidly where we'll have 100,000 new COVID-19 cases per day. And implicit in that depending on the figures, that we'll have something like 10 to 20,000 new long COVID cases per day. And because of the demographic of where those cases are spreading, that'll be particularly within our secondary schools and our universities. Sorry, I seem to have jumped. Hang on. That'll be particularly within our secondary schools and universities. And as I alluded to before, I think we're almost scared to address the enormity of the questions, because this really does have implications for our society, for our healthcare provision planning, for education, and certainly, again, trying not to be political here, but questions almost too big for our politicians to be able to address in the heat of battle. So we've seen many versions of this in the last few hours, so I won't dwell on this. This is one of the versions that I like of the symptom profile. It comes from a very good paper from another long COVID sufferer, from Hannah Davis and her colleagues at University College. But it makes the case, as you've seen in other people's slides, that you all know very well, that this is diverse and variable and multi-system and multi-organ. So let's agree on that and leave it at that. So how can I, as a professor of immunology, do anything to help to narrate the story, the pathophysiology of this massive phenomenon of a variable, fluctuating, relapsing and remitting set of symptoms affecting almost every part of the body? Yeah. So I think I mentioned before that try and see it from both sides of the table. Try and see both the devastated, desperate, impatient patient who's just had enough. And sorry, so for some reason my slides are jumping. Let me just go back a minute. Oops. Let's go back. Giving away my punchline. Yeah. So you're on the one hand, you might be on one side of the table. You might be the desperate patient, just really thinking, why won't anybody give me any answers? Or you might be on the other side of the table. You might be the junior doctor who's been told by your consultant that you're now in charge of the long COVID clinic, and you don't know what long COVID is. You were never taught anything about it in medical school. There's been no chapter on it in your general internal medicine textbook, and you haven't got a clue. All you see is a very, is panicked people on both sides of the table. So let me give you a metaphor from another disease, which I hope you won't find it labored. You might find it helpful. So imagine you are now that junior doctor sometime in the past, and you're sitting in your clinic, you're now the doctor, and a young woman comes in to see you, and the first time she comes to see you, she complains of breathlessness and wheezing and respiratory problems. And the next time she comes to see you, she's worried about her hair loss and her high fevers. And the next time she comes to see you, it's about her painful joints. And then another 3 months goes by, and she's got a whole new set of problems to do with her kidneys and blood in her urine. And another 3 months goes by, and you wonder what on earth is going on, because this time it's all about the rash on her face. And, how can so many different things be going on? And, is she really ill? And if so, what with? Or maybe she's just some kind of hypochondriac or attention seeker. And, many people will have realized that what I'm talking about here is a person with lupus. So I hope you can see that, the metaphor is of some value, because, one disease process, one molecular mechanism, and all these different parts of the body affected. But if you missed that textbook chapter and didn't know the cause, you might think it was a crazy person, who had all these sort of different things apparently wrong with them. And so in the case of a disease like lupus, it's taken a very, very long time to decode the story. If you sort of eyeball this timeline from a paper about the history of lupus, over the last, 1,500 years, we've gone from little understanding of the phenomena, and the cure was going to visit the shrine in France, to modern medicine, where there's a very good molecular medicine explanation of lupus as an autoimmune disease, and we'll come back to that in a moment. And so over the last 40, 50 years of appreciating that it's an autoimmune disease, where almost a single step, a faulty immune response, making autoimmune antibodies to parts of your DNA and proteins complex to your DNA, can lead to all of these diverse disease processes. Okay, so if I try and fast forward from that and think, well, if it took us 1,500 years to get that far on lupus, how are we going to fast track that into hopefully a year or less of research in long COVID? We've had various discussions of this before, but the kind of hypotheses that our lab put forward and others, both in that BMJ article and in the World Health Organization document, are all of the obvious, really. The thing that Betty mentioned about how many ACE2 positive cells in many organs in the body are affected, and there may simply be the thing that you see on MRI or on CT scans, scarring and fibrosis in different tissues, that hopefully gets better with time. A lot of interest in a coronavirus doing something it was never meant to do in the textbooks, that's setting up a kind of long-term persistent reservoir of infection. A lot of interest and some evidence for virus being present in the long term in the gut. And you can do that in different ways, both by looking at people who are being investigated, because of things like their inflammatory bowel disease anyway, or the other trick that we like is simply getting a poop sample and using a PCR to amplify virus out of poop and showing that many people do have it there persistently. What we don't yet know is whether that's a specific correlate of long COVID or just something that happens in some people after COVID. Oh, sorry, I've jumped again. We'll talk about another hypothesis that acute viral infections cause immune subsets, and we'll talk about that in a moment, to be perturbed and dysregulated. And then the last hypothesis that I'm rather keen on, and we and others have some evidence for, that we can think about long COVID as an autoimmune response, a bit like the example I gave from lupus. So let's explore some of those things. So I've now used the term autoimmunity quite a lot, and we all, I guess, vaguely understand what we mean by that, but just to kind of home in on it. So for folks like me, the immune system is a wondrous thing. It's not just a sort of single type of white blood cell. It's many thousands of different types and subsets of white blood cells that do things all around your body and obviously make products. The best known one are the antibodies. And the reason that they have such an enormous evolutionary value for all species is that they're the way that we fight unwanted invaders, whether it's viruses or bacteria or fungi or cancer cells. And we also have known for a long time that this very complex regulated immune program sometimes goes awry, so that instead of recognizing foreign targets, the jargon name for that is antigens, they start to recognize antigens on human cells, on your own cells. Examples like recognizing joint antigens leading to arthritis, or the myelin sheath of neurons leading to multiple sclerosis, or the cells that make insulin leading to type 1 diabetes. And the reason I think it's useful to know this and think about it in this way is that I think it does lead us to answers and therapeutics, because recent decades really have been a kind of golden age for autoimmunity research and for translating that research into understanding of mechanism and into many, many newly licensed drugs that have made a big difference to people. So you can see my direction of travel here, that if we could tell this story better, we could do things for people. So in the past, we've known of many examples where virus infections lead to long-term symptoms. And for my taste, if we can learn from these and define molecular mechanisms, we can design precise diagnostic tests for health service use. And for all the reasons we've discussed this morning, that in itself would be a valuable thing, I think, because then people start to have a clear, unequivocal diagnosis that they can take to their hospital, to their doctor, to their employer for that matter, and start to negotiate what's going to happen next. But it's not just that, is it? Because if you knew, again, by analogy to any of those autoimmune diseases, what was causing it, you can then turn to that vast toolkit of goodies we've got for treating autoimmune diseases and begin to look at what one can do to get rid of those the symptoms. We've talked about some of these things. So we know the evidence for fibrosis. We've seen the MRI changes and CT changes, and we've seen the evidence that some people have persistent virus in their guts and in their poop. So just to tell the story of some of the bits of evidence from some of those other virus infections I was talking about. So one of the quotes that I've used, probably overused, is that acute viral infection can be like throwing a hand grenade into the immune system, dysregulating the normal immune subsets. One of the best examples of this that I've ever seen is glandular fever, the way that Epstein-Barr virus infects often young people, and they get glandular fever or infectious mononucleosis. And many of them are not just laid low by the acute infection, but it can take them years to get back to normal in terms of their state of health, their susceptibility to other infections. And there's an immune system explanation for that, because their immune system really has been hijacked here in terms of a kind of T cells called CD8 cells. Here's another example from another infection that's been mentioned today already, Ebola virus infection. We all know that Ebola causes acute disease and death from a kind of hemorrhagic illness. What I think fewer people know is that even among the survivors, there's a really high prevalence of, the kind of things that'll be familiar to you, headache, joint pain, muscle pain, memory loss. and a lot of work ongoing to try and understand that. So that's two examples from quite diverse viral infections. Here's one of my favorites. Our lab does a lot of work in Brazil. We work on an infection caused spread by mosquitoes called chikungunya. The reason I bring up this analogy is because, again, it's not just the acute infection that troubles people, which is looks a bit like dengue or Zika. It's a fever and a rash. It's the fact that a sizable minority of people go on to get an autoimmune arthritis, and that devastates them. It puts them out of work, it puts them out of the economy. It also, in countries that are affected widely by it, like Brazil, affects pressure on the healthcare system. Yeah, so you can see why I kind of bring up these examples. So these are the kind of examples that certainly in my lab and other immunology labs are informing the research that we're doing, working with people who have long COVID, to try and understand what on earth it's all about, therefore, and thus, what we can do for people. And to finish, this is an example of the kind of work, not from our lab here, but from Yale, from Akiko Iwazaki and Aaron Ring. And so this thing that looks like a kind of starry night, every time there's a dot lit up as a color, that's an antibody that bound to a human protein, in this case, either from central nervous system or from the vascular lining, showing you how, as a consequence of COVID-19, a whole new array of autoimmunity can be set up. And our mission at the moment, and I think the same in some other labs, is to try and tell that story and work out which autoimmune profiles could be responsible for long COVID, which we think will lead us to diagnostic tests and to therapeutics. So I think that's my last slide. So I'll end my slideshow there, and we'll probably revisit some of these things in questions. Thank you. Stop sharing.
Thank you very much, Danny. Thank you for the fantastic talk. I think Mary is going to introduce our second speaker of this session, and then we'll have the Q&A at the end, as we did last time. Mary, are you there?
Yes, I'm there. Yes, thank you, Danny. It was very, very interesting what you just told. I would like to introduce the final speaker, Dr. Rhiannon Cole-Cedar from the Sortia Hospital in Athens, who would like to be able to talk about long COVID rehabilitation center that she is running.
Okay. Well, good afternoon to everyone. Thank you for being here and joining us online. My name is Rania Cole-Cedar. I'm a respiratory physician working in Sotiria Chest Diseases Hospital in Athens, Greece. I would like to thank the organizing committee for the kind invitation. I've been involved with COVID-19 patients since the pandemic started in Athens, and I'm in charge of the outpatient clinic for post-COVID-19 patients. And recently we have organized a pulmonary rehabilitation program for all these patients. Within the next few minutes, I'll try to explain what is pulmonary rehabilitation and why post-COVID-19 patients need it. First of all, pulmonary rehabilitation is a comprehensive intervention based on a thorough patient assessment followed by patient-tailored therapies, which include exercise training, education, and behavior change. It is designed to improve the physical and psychological condition of people with chronic respiratory diseases and promotes the long-term adherence of health-enhancing behaviors. The components of pulmonary rehabilitation are general exercise training, breathing training, and secretion clearance techniques. It also contains psychological support and patients' education, self-management. It includes nutritional advice, often smoking cessation, and of course, patient outcome assessment. Yes?
I'm sorry to interrupt. Are you projecting slides at the moment?
Yes, I am. You
So
cannot see them?
we're not able to see them at the moment. I'm
Okay,
terribly sorry.
okay. Yeah, wait. Okay, I'm really sorry. Do you want me to start all over?
No, I think we got what you were saying.
Okay.
But maybe just go to presenter view.
Okay, excuse me. I'm really
no problem.
Sorry.
Thank you.
Okay, so the main goals of pulmonary rehabilitation is to improve the body composition, increase physical activity, and promote mental health. It also helps to manage acute dyspnea, minimize everyday symptoms, detect and manage acute flare-ups of the disease, optimize pharmacotherapy, and also it facilitates smoking cessation and helps to establish social networking. When we talk about pulmonary rehabilitation, we need a multidisciplinary team consist of pulmonologists, physical medicine specialists, social workers, psychologists, nurses, respiratory therapists, occupational therapists, physiotherapists, general practitioners, pharmacists, and dietitians. And the benefits of pulmonary rehabilitation is, first of all, to minimize symptoms, reduce the intensity of breathlessness and lung discomfort, to improve muscle strength and patient's endurance, maximize patient's exercise performance, increase physical activity. It also enhances confidence, knowledge, increases patient's participation in everyday life activity. It also reduces anxiety and depression, and it helps to improve the psychological well-being of the patient. Finally, it improves health, quality of life, and increases survival. So, taking into account all the above mentioned, I'll try to explain why pulmonary rehabilitation is needed for post-COVID-19 patients. As you already heard, COVID-19 pandemic has created serious problems for global health and various types of complications and levels of functional impairment in millions of individuals recovering from the disease. As you already heard, post-COVID-19 patients suffer from symptoms such as fatigue, weakness, even a year after. They also complain of shortness of breath, dyspnea, cough, joint pain, chest pain. They have heart palpitations. They have problems with concentration and memory loss. Some of them complain of muscle pain, headaches. They sometimes feeling sick. They have loss of appetite, loss of smell, and many of them have problems with sleeping and depression or anxiety because of the post-traumatic stress. So the aim of post-COVID rehabilitation is to support a full recovery, to support symptom management, and to support a return to normal life. So when to start the program? As an outpatient, this is for patients with mild disease. As an inpatient, during hospitalization, even start in the ICU setting, and post-hospitalization, 6 to 8 months weeks after discharge. And where to start the program? As I already told you, rehabilitation starts within the hospital, within the ICU setting, or it's for outpatients 6 to 8 weeks after discharge, or there are some home-based programs for patients that that are not able to go to the hospital to have the session. Clinicians should be very careful with patients' evaluation before starting a pulmonary rehabilitation program. They need to assess the need for oxygen at rest and physical exertion, the dyspnea level, and also assess patients' physical, cognitive, and emotional status. They need to test peripheral muscle strength and also assess respiratory function by using spirometry. They need to check for heart problems and also assess patients' nutritional needs and be very careful with comorbidities. Clinicians also follow preventive measures, wearing the appropriate personal protective equipment according to local policy, and rehabilitation treatment plans should be individualized, as I already told you, according to the patient's needs and taking into consideration their comorbidities. Rehabilitation should be aimed at relieving symptoms of breathlessness, minimize everyday symptoms, and improve patients' health and functionality. Patients should be reviewed through the rehabilitation process before and after. They should receive education about their condition. We need to explain how to manage recovery, how to manage their everyday symptoms. Programs usually start 6 to 8 weeks post-discharge and last for about 6 to 9 weeks. Patients come to the hospital 2 to 3 times a week, and sessions usually last 1.5 to 2 hours. We start with low-intensity exercise, particularly for patients who still require oxygen therapy, while we carefully monitor vital signs, heart rate, pulse oximetry, and blood pressure. And we gradually increase the intensity of exercise based on patients' symptoms. And the programs recommend that patients should have a frequency of 3 to 4 times a week program for at least 45 minutes per session. And the exercise type includes walking, biking, muscle strength exercises for upper and lower extremities. It also includes airway clearing and breathing exercises such as diaphragmatic breathing, pursed lip breathing, and active abnormal contraction. Don't forget to educate patients, educate them about the clinical course of the disease, encourage lifestyle changes like adequate sleep, hydration, and proper nutrition. And also, it's very important to the psychological intervention to counsel about social support and also psychiatric consultation. Where in Soteria Hospital, we organized a pulmonary rehabilitation program. We recruited first group of 15 patients post-COVID, 5 male and 10 female, aged 42 to 65 years old. All patients were hospitalized in the second pulmonary department of Soteria Regional Chest Disease Hospital in Athens, Greece, during February and March 2021. They were all critically ill. They suffered from respiratory failure during their hospitalization, and they had lung infiltrates in the CT scan. All of them complained about fatigue, breathlessness, palpitations, muscle weakness, inability to work and concentrate, and lots of them had anxiety and depression due to post-traumatic stress 8 to 12 weeks after discharge. The duration of the program is 8 weeks. Patients come 2 times a week, and the session lasts for 1.5 hours. It contains supervised exercise training, breathing rehabilitation, and airway clearance. And the program also includes dietary consultation, psychological support, patient education, cardio function tests, and follow-up with CT scans, chest CT scans. And all patients underwent the primary evaluation, included dyspnea scale. We checked blood gases, lung function by spirometry. We also did 6-minute walk tests, sit to stand tests, and blood tests to check thyroid function. We checked whether there were heart problems, and also we use quality of life questionnaires, quality of sleep, and post-traumatic stress questionnaires. So our patients will finish the program in July 15th, and all of them undergo all the tests included in the primary evaluation. I can assure you that already all of them feel much better. Their dyspnea and fatigue have decreased. They are more self-confident and have less anxiety. All of them made lifetime changes. They started workout, and they are more active in their daily activities. So in conclusion, pulmonary rehabilitation is one of the most effective management strategies to improve shortness of breath, to minimize everyday symptoms, to improve health status and exercise tolerance of patients with pulmonary disease, and for patients with post-COVID-19 symptoms. So I believe with proper measures and the immunization, we will be able to overcome this pandemic and its consequences. Let's all hope for the best. Thank you very much for your attention, and enjoy your summer holidays. Thank you very much.
Thank you very much, Rania. That's a really lovely presentation and also a really encouraging message to finish with, to hear that so many patients benefited from the pulmonary rehabilitation exercise. As respiratory physicians, and obviously as the European Lung Foundation, we come from a respiratory background. We're used to pulmonary rehabilitation being the best possible treatment for a lot of respiratory conditions like COPD or interstitial lung disease, for example. And so I'm not surprised to hear really encouraging results early on also for patients with long COVID. So we're going to move now into the final Q&A session, which is going to be focused on treatments. I'm going to welcome back Danny, we're going to welcome back Marianne, and we're going to welcome back Betty as well, if Betty's still there. So we'll now go to the audience's questions. Please keep asking your questions through the Q&A function, and we'll try to get to as many of these questions as we possibly can in this final session on treatment. I'm going to take Chair's prerogative to ask the first one, though, because I'm really interested, Danny, in what you said about autoimmunity and could COVID be an autoimmune disease. Am I wrong to think that what Betty presented, that the most common age group is middle-aged and the most common patients are female, that's also the age and gender of patients that also are more likely to have autoimmune disease? If that's the case, is there data showing that the sort of phenotype, the immunology is similar between autoimmune diseases and COVID?
Yeah, no, I think it's a really helpful point, isn't it? Because autoimmunity is much more common in most cases in women than in men, and that's never been entirely perfectly pinned down. But it wouldn't take a genius to work out that's to do with hormonal differences in impacting development of the immune system. And so if you try and join up the dots between that and our discussion today, we're part of the way there, aren't we? Because lots and lots of observations on how COVID infection per se leads to new patterns of autoimmunity, including those kind of pictures I showed. And some really impressive data, for example, showing how people who've had COVID have lots of antibodies against proteins in their skin. And you'd love to be able to say, what does that have to do with the rashes that people see in long COVID? So the final bit of that circle hasn't been squared yet, but I think it will be soon. And I think that'll be really helpful.
Yeah. So this is a follow-up to that would be obvious for a lot of autoimmune diseases. What we do is we suppress the immune system with things like steroids. And we started using steroids in the middle of last year as a treatment for COVID. Question Danny first and then maybe Betty as well. Is there any evidence so far that as the pandemic's gone on and we've used more drugs that suppress the immune system, we've seen less long COVID, or it's had any impact on long COVID?
I'd be keen to what Betty thinks. I don't think I've seen or heard of any evidence like that. Or even just that steroids, sure, but even the aggressive use of antivirals could have had some impact on long COVID. And I don't think I've seen evidence for that yet either, but I'd be keen to hear any other evidence. But I was being a bit coy talking about the toolkit and the goodies on the shelf, but there is an awful lot of stuff out there apart from just steroids, if we only knew which stuff to try and put into proper trials, and that's getting closer.
So Betty? I can add to that. So there aren't any evidence from the recovery trial investigators, as Danny quite rightly pointed out. And I think that'll be really valuable because they have a really rich resource there. But we do have some data from the FOSS-COVID consortium. So the FOSS-COVID group of investigators have put out the first paper on 1,000 patients across the UK, and they did not find an association between the use of steroid and recovery. And recovery is defined by very subjective, like how the patient feels from a symptom perspective. So that was quite interesting.
Yeah. So a lot of our patients are looking for kind of practical tips about what they can do over the next few months with their symptoms. So I'll start with you, Rania. So you showed the nice rehabilitation program that you've got. a lot of our patients will live in places where they can't access rehabilitation programs like that, or they haven't been referred. Are there things that patients could just be doing themselves that could try to at least mimic some aspects of the program you've described?
Yes, of course. We advise all patients start even, walking outside, minimal exercise with safety. Unfortunately, patients that need oxygen therapy after discharge, it's not safe to start something like that. They need respiratory physician consultation, pulmonary consultation, and so it's difficult for them to exercise. But for patients that were not hospitalized and they still feel they complain about fatigue and dyspnea on exertion, they can start exercise, let's say for about 10 to 20 minutes a day, and gradually increase time and intensity.
Yeah. And if patients do experience that sense of real exhaustion, hours after or the day after exercise, what's your advice? Should you try and exercise through the fatigue, or should you rest? That's a really common question we get.
You need to follow them up. You need a CT scan to check if the infiltrates are still there. Maybe you need a spirometry to check their lung function, and also you need cardiological evaluation, because some of them suffer from myocarditis. It was not diagnosed during the hospitalization. And also you have to be very careful with the patients that suffered from pulmonary embolism or deep vein thrombosis during hospitalization. You need to be very careful with those patients too.
Yeah, so that's coming also through in the Q&A and in the chat. Some patients saying I've been diagnosed with myocarditis, some saying I've had a pulmonary embolism, but an awful lot of patients saying, sort of as going back to Danny's analogy, they've just had the consultation with somebody who said you've had long COVID, but they've not necessarily had many tests. And so it seems to be quite inconsistent. Maybe a view from everybody on the panel on how patients can access testing, or what kind of tests people should be expecting. Maybe start with... Yeah, go, Rania.
We follow patients to the outpatient clinic, and we actually have a protocol. We see them within a month after discharge, and all of them have blood tests, a CT scan within the 4 to 6 months, a spirometry if they still feel dyspnea, and also they have blood tests and an echocardiogram. And actually, we detect problems. Yeah, patients that still have symptoms, they end up with problems.
And maybe Betty, do you want to expand on that in terms of testing?
Yeah, thanks, James. So, I mean, I think this is quite a complex question, because in some ways it really comes down to a balance between benefits to patients from doing the investigation and the costs of the investigation. So if I were given, an unlimited well of money, sure, I'd do all my fancy investigations. But I think from a primary healthcare perspective, I'd hope that there's at least sort of some basic screening test that gets done to exclude the more major complications. So, for instance, cognitive assessment, ECG, 12-lead ECG in someone who's complaining of palpitations or chest pain, some basic set, or even blood tests to look for troponin and BNP, some basic investigations at the GP level. And should any of them be abnormal, then you're quite sure that this is actionable and it needs to be referred on to a specialty service. Now, if I had all the money in the world, I'd do my multi-organ scan on everyone and look for, look to see if there's something that could explain it, because, I'd like some answers. I need some tangible, outcomes. I need to see what's going on. And so, yeah, that's really how I'd manage it if it was up to me entirely. And if I had all the money in the world, but neither is the case right now. So
Yeah, I mean, I think it is an important point. Danny's slide about, we're potentially making 10 to 20,000 long COVID patients a day in the UK. We don't have enough scanners to scan that many patients. We cannot scan 10,000 patients a day, so we do need investigations that are practical. Another set of questions that's coming through a lot is around the brain fog and how to cope with that. I think that's difficult, obviously, because we don't have trials. But Marianne, you mentioned that that's something that you've experienced. How have you coped with and managed that as a symptom?
Well, I still have it, so and now I'm completely exhausted, so I will rest the next couple of days. But so what I do is, what I find is easier for me is when I started doing breathing exercises, and then I take cold showers. That has lifted my mood. That has lifted my clearance. I get still quickly exhausted, but still, that is what I try to do. Even if I do, I did some push-ups for a period. Just before I went to bed, I did some breathing exercise and I could do push-ups. Before I got ill, I did 40 push-ups and like around 6 to 7 chin-ups. So I was fairly strong. Now I try to do for 5. And then before I did the breathing exercise, first I did the breathing exercise and then I could do this without anything. But then for me, this illness goes up and down. So I cannot give a clear answer on the brain fog. But I still try to do some brain tasks to keep the brain active. But yeah.
Yeah, and I'm curious, Rania, whether you've seen with some of your patients that your program is helping with the neurological symptoms as well as the physical limitation.
Actually, to that program, patients didn't refer any neurological signs. Most of them complained of fatigue and dyspnea on exertion, and they had problems, to concentrate and to be able to work, actually. So the exercise and the breathing exercises help them. And also the psychological support helped them to just overcome this post-traumatic stress.
Yeah. So a lot of the problems that we're having in answering the questions about what to do is we just don't have enough data. So, and it's very difficult for doctors to make a really firm recommendation when we don't know what causes something. Or Danny, because I know you've written about this in various forms, how do we as clinicians cope with uncertainty? So when we don't know the answer and there's a lot of anecdotal evidence around, how do we help people? Because we really want to help people, but we don't always know the right answer.
Yeah, no, really, really important question. So, the first thing to say is that things in time of COVID have moved forward really, really fast. And there's a real will to foreshorten all of these debates and, do things that used to be done in 6 years and get them done in 6 months. And the secret is just all of the obvious, isn't it? It still puts pressure, I'm afraid, on the patient groups because they've really led the way. So they have to continue to be demanding and to press the point and press the demands and press the referrals. And then the doctor needs to listen, and we need to design the right trials to actually investigate our hypotheses and get the answers they need. It's all of the obvious, but just done at warp speed.
Yeah, and also being brave enough to say when we don't know.
Yeah.
Betty, anything to add to that?
No, I think everyone's essentially read my mind. These are all very important discussion points that will continue to evolve over time.
Yeah, so we've only got a couple of minutes left before the end. And so I want to go round and just give everybody a chance to give their kind of top tip or, what I would do over the next few months, either advice to the patients that are listening, or we've got a lot of healthcare professionals, what should we be focusing on? What should we be researching? So I'll go in the order that you appear on my screen. So starting with Rania, what do you want people to really take away today?
We don't have still all the answers, but we will be soon. And I hope we will overcome this pandemic and its consequences. And as a clinician, I encourage my patients, to stay calm and to be productive and to start be active and, live their life. They should be, lucky that they survived all this. So they should do their best to come back to their life and their families.
Okay. And Marianne, anything else you'd like to say to your fellow patients or to the clinicians that are listening?
Sorry, I have to unmute. I would just say for the long haulers like me that the breathing techniques, I think, and the cold shower is good, and still try to do something good for your brain. I do meditate, but I'm starting to be a little bit sort of impatient for this because here in Denmark they say that you should rest, and I'm tired of resting, to be honest. So the breathing techniques and the cold showers, definitely.
Great, thank you. Danny?
Yeah, no, all I'd add is I'd like people to try and keep up their optimism, because I do think that there are answers on the way. Honestly, I think all the right things are being done, and I think there will be diagnostics soon and there will be therapeutics soon. And all you can do in the meantime, I think, is to continue to be a very demanding patient who really irritates your doctors and irritates your policymakers to make your demands, because how else are you going to be heard?
Yeah, that's permission from Professor Altman of Imperial College to be as irritating as you like. Betty, final word.
Yeah, so I mean, I was going to say exactly that. I think we've learned a lot from this session, just as much as the patients have, and and physicians managing them. And I really think that such forums where we're able to interact with each other and share our concerns, and be honest about what we don't know, and where we need to channel our funds and our energies and minds to answering. So I think this was a really, really exceptional session for me, and it's definitely reframed a lot of my questions. And I'm really determined to continue researching and continue trying to answer many of these questions and keeping an open mind about long COVID.
Yeah, and I think that's absolutely terrific. I sort of said that would be the last word, but a couple of further questions have come in that have really sort of piqued my interest. So I'm going to ask you a couple more questions, if I may. A few people asking, what are the parallels between long COVID and chronic fatigue syndrome, or ME? And is there anything we can learn about treatments of those conditions that we could apply to long COVID? Or in the reverse, a bit like the sort of analogies between COVID and flu, can it sometimes be a little bit dangerous to try and relate one disease to something else? I'll go in reverse order, so give that one to you first, Betty.
Sure. So, I mean, so people who've had chronic fatigue syndrome say that when they look at or listen to others who've now been diagnosed with long COVID, that they're basically looking at someone exactly like them, so someone in the mirror. And the point they're trying to make here is that there are a lot of symptoms in common, but there have been some reports where there are some symptoms that seem to be more prevalent or more dominant among long COVID patients. One of them is brain fog. And so I suspect what's going to happen is that among patients who have long COVID, there will be a subset, fairly large subset, in whom there will be quite a bit of overlap with chronic fatigue or CFS, and they might end up having similar sort of treatment options. Now, what are the treatment options? I have to say, I'm not an expert in CFS, so I can't answer that question. But there are therapies out there that are being tested and trialed. Exercise is controversial, but that's where I'll stop for that answer.
Yeah, and I'll give the same from an immunology slant, Danny, to you. Is it a good idea to use analogies, which might be lupus or CFS or Epstein-Barr, or potentially misleading?
No, I think it's definitely helpful and useful. I get asked a lot about chronic fatigue syndrome, and my answer is always a bit unsatisfying. It's a kind of Rosetta Stone answer that I don't understand one, and I also don't understand the other. but I hope that by understanding a little bit of both, I can kind of, maybe do some decoding.
Yeah. That's. Do we know anything about the immunology of CFS? Like Betty, I'm not an expert on this.
Not much, not enough, and not much.
Yeah. So it emphasizes yet again this key point about doing the research and doing it rapidly and at scale. So I think we'll wrap things up there, because I think that's a nice point to end on in terms of we've had a fantastic day. We've had 3 sessions addressing different aspects of long COVID. We've talked about what it is, we've talked about what research needs to be done, and now we've talked about treatment, both in terms of what we do know, what we don't know, what we need to know going forward. I think some of my takeaways today, a lot of it is stating the obvious, but it's to say this is a really big problem, and I don't think internationally policymakers have necessarily grasped just what a big problem this is. The fact that we had 1,600 registrations for this conference tells you that there's a lot of patients with long COVID, and there's a lot of healthcare professionals with great information needs around how to manage long COVID. And I think that's a really important takeaway message from today. We've learned that it's a very diverse condition, that patients have many different symptoms. Fatigue is the dominant symptom, but you'll remember from the first session that the number of symptoms couldn't be fitted onto one slide. It's such a diverse condition. And Danny reminded us very nicely of in medicine we have lumpers and splitters, and just because there's different patients with different characteristics doesn't mean that it isn't the same condition, and that the treatment may not be very similar for all of these different types of patients. We've heard really powerful stories from patients today, the videos that we've had of both their challenges in getting diagnosis and being understood and finding the right treatments. And that's going to be difficult for people all over the world because our healthcare systems work differently. Even within the UK, we have long COVID clinics in England, but not in Scotland. And so when we take into account that we have registrations today from 100 countries, how care is delivered in those countries is going to be very different for people with long COVID. And so as well as finding treatments for this condition, we also have to think about what's the best way to deliver that care. And Rania's talk was one example of a successful way of delivering a rehabilitation program to patients. But we will have to find best way to treat patients in our own healthcare systems in our own way, and cope with the scale of the number of patients that we're going to see with this problem, because so many people have had COVID. We now know that a lot of patients are going to have long COVID. The final message is one of hope. We haven't been able to give you the magic cure for long COVID today. None of you came to this conference expecting we'd be able to do that. But I hope we've given you information that's useful to manage your condition on a day-to-day basis, or to manage your patients if you're a healthcare professional. But most importantly, I hope that we've shown you that researchers all over the world are working day and night to try and understand this disease, to try and find the mechanisms, what's causing it, because once you understand something, you can treat it properly. And we're very close, as all of our speakers said, to having treatments both from a rehabilitation perspective, but also potentially from a pharmacotherapy perspective, to be able to offer to patients to make them feel better and to reduce the burden of long COVID. So the final message is we will get there. We will find a way to mitigate this problem and to help our patients. I hope the day has been educational. I hope it's been interesting. And I hope for the patients that are listening that it's given you some hope and some relief, and that you'll take away from today messages that are really helpful for your life going forward. So thank you. I want to finish by saying thank you to the European Lung Foundation and to Dragon, who organised today, both organisations that are really committed to engaging with patients and to bringing patients and clinicians together. Thank you to the technical team in the background who have kept things running. And thank you also to Marianne, who co-chaired with me through the whole day, and to Danny, who chaired the second session. It's been a fantastic team effort to deliver this conference today. And again, I hope you found it valuable, and have a wonderful Saturday. Bye-bye.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye.